We're here with Dr. Lily Tran and Dr. Mary Zupanc, and we're going to have a conversation about infantile spasms. And it happens in about 1 to 3 of 10,000 births. And we know it happens roughly in the first 3 to 8 months of a child's life. That's not always the case, but that's generally the case according to most medical journals. And we do know this: they're often hard to detect, and they're almost always catastrophic if they're not diagnosed early. Catastrophic in the sense of potential permanent brain damage, potential impact on quality of life for a child, and sometimes, unfortunately, even death. What we've realized at Mickie's Miracles is that we get referrals from families long after someone should have caught the infantile spasms. So we get families that have, been to their pediatrician, have been in the emergency room with a pediatrician, have maybe gone to a neurologist, and it's been missed along the way. So by the time they get referred to us, there's already some critical danger present in most cases. So part of what we're trying to do is number one, help primary care physicians and emergency room physicians understand, what to look for and what to do if they suspect infantile spasms. And secondly, impress upon, the entire community, certainly the medical community and the primary care emergency room pediatric community, but certainly the general population about the urgency and danger of infantile spasms. So Dr. Zupanc, you're obviously one of the leading experts on IS. You created or have part in creating one of the most comprehensive pediatric epilepsy centers in the country. You've written 15 chapters for pediatric neurology. You know this stuff pretty well. So let's start with you. Tell us what infantile spasms are and why they're so dangerous.
Well, I would submit that both Dr. Tran and I, who have worked together, are both experts in infantile spasms.
Oh, yeah, absolutely. Yes.
And
yes, of course.
So I'm just giving that little caveat, but certainly we have both seen, and many of our colleagues have seen, children who come into our office who've had infantile spasms for months, sometimes years, unrecognized and untreated. And so the prognosis, what's going to happen to them in the future, is dependent on several variables. One is when the diagnosis is made and how soon it is treated, but also the underlying cause of the infantile spasms. So those are two very, very important variables. And unfortunately, we see children who are not diagnosed with the underlying cause or treated. But infantile spasms are a cluster of either what I call flexor, that means myoclonic jerks. It's slower than that, but just movements that occur every 5 to 10 seconds, sometimes lasting for 5 minutes, sometimes morning, when a child arouses from sleep. And parents recognize that something's odd about this, that it's different. It's not normal. It's not a normal baby startle. So they recognize that it's abnormal, but oftentimes when they bring a baby into an emergency room or their PCP, describing these moves 5 to 10 minutes over 5 minutes to 30 minutes, that's a difficult task for anybody to do. And so what I would advise, if a parent sees something, they should take a video, because a picture is worth 1,000 words. And that sometimes is very helpful. Unfortunately, many emergency room doctors are adult ER docs and are unfamiliar with infantile spasms. So that's why we're trying to do an educational program informing not only primary care providers, but emergency doctors what infantile spasms are. So if we had some videos here, you could go onto YouTube and click infantile spasms and really see a good library of different types of infantile spasms.
Yeah, and we have some on mickiesmiracles.org of Mickie. And like you said, they're very subtle. And if you don't know what you're looking for, they're hard to miss. You know, Christy tells the story obviously very powerfully, but she didn't know what was wrong, but she knew something was wrong. But her first course of action in terms of who she took Mickie to see, you know, just didn't have the experience and expertise to be able to identify it, let alone treat it in, you know, the correct way. Obviously, that's when they met you, Dr. Z, and I know that both Christy and Gabe, you know, credit you with saving, you know, Mickie's life. So thank you for that, because we love her very, very much. Dr. Tran, she's the epilepsy director.
Well, it was a whole group.
Yeah. No, I know it's a team effort over there. I've been to the facility, and it's a world-class facility, and you guys really do a great job of taking care of the families in your care. So we recognize that and appreciate that. And Dr. Tran, you know, we know you've been in the field for, you know, 10 years now as a, you know, neurologist, and you're currently the epilepsy director at Nemours Children's Health and the EEG director. And we're so grateful for your relationship to Mickie's Miracles. You've been such an asset in helping our families, you know, through the years, and we're happy to have you. So what, I guess, if you had to define infantile spasms, I know they're basically a cluster that Dr. Z talked about, but in terms of, if you had to define infantile spasms, how would you define that? Like, what would the definition be?
So in terms of infantile spasm, much like what Dr. Zupanc said, is a cluster of exaggerated startles, you can say, that occur in the first 2 years of life. And it's we call it, in our world, we call it epileptic encephalopathy, right? It's one of those epilepsy syndromes that to an epileptologist and neurologist is an emergency, because if we don't treat it or recognize it in a timely manner, it can have a negative impact on a child's neural development down the line. And so we go into pediatrics because we want to have an impact and allow kids to live life to its fullest, right? And so things like infantile spasms, where it's an epileptic encephalopathy, and I'll go into what that means too, it can have a negative impact on the children down the line. Sometimes you may not see it right away, but many times you can. There's some subtle changes in development that oftentimes occur within a week or two of spasm onset. And so it's actually you can see its impact on neurodevelopment immediately or soon upon its emergence. But if not treated or recognized appropriately, it can continue to have bad effects on the child's neurodevelopment that can affect their life downstream. And so that's why for us in pediatric neurology, we want to make sure we ensure these children live life to its fullest. And that's why we'd like to engage in programs like this to increase awareness, right? The more people are aware, the more people recognize it, the better the outcome for our children. And so going back to what I mean by epileptic encephalopathy, it means a syndrome where the seizures are so frequent that it affects the brain's ability to develop appropriately. And as part of infantile spasms, there's an abnormal finding on the EEG, which is the brainwave study. So it's the study that we look at the brainwaves. So our brain works on electricity, right? And so there's normal patterns of electricity. And when there's abnormal patterns, we kind of like, what's going on here? And sometimes these abnormal patterns is pathognomonic for certain syndromes. And so with infantile spasms, there is an abnormal EEG pattern that is pathognomonic called hypsarrhythmia. So the diagnosis includes the cluster of seizures that Dr. Zupanc has described, and accompanied by this abnormal EEG pattern called hypsarrhythmia as well. And it affects a child's development, where within a week or two, you can start seeing regression in these children. Right. Both Dr. Z and I have seen it, where these children are developing, and parents like, yeah, within the past week or so, they started smiling less. They start babbling less. The eye contact has been reduced. They don't have as good eye contact. things they used to be able to do, like they're just starting to sit, but now they're not able to anymore. And so we can take a careful history on these children. Parents are with their children 24/7, so right. they know something's off with their children, and they often say within that, yeah, little Johnny's not smiling as much, or little Susie's not babbling or cooing as much. And so there is signs of developmental regression, and that's what we want to halt already. And that's why our push at epileptologists to increase awareness to our primary care providers like pediatricians and family medicine doctors, as well as emergency room, because they are the frontline doctors for this already. We oftentimes don't see them first, unless the parents know of someone who knows of someone who knows of someone. Right. And oftentimes it's our pediatricians, our primary care providers, and emergency room doctors who are the frontline, call it the frontline players or whatnot, who recognize and help these children tremendously. And the only way they can help and recognize it is to increase awareness. So things like this to show them, when should you be concerned about infantile spasms? It's when the history has these parents saying, my baby's starting to do clusters of abnormal movements, right? So abnormal movements meaning what Dr. Z has described, head drops or flexion of their shoulders and followed by extension. One mom called it thrillers. They just thrill repetitively. Some parents just head drops repetitively. So if the parents come in reporting repetitive movements that don't seem right, and they're associated when the children falls asleep or wake up from sleep, usually when they're waking up from sleep, and they typically say, yeah, and I've noticed my child has not been acting normal, where they're not talking as much and not looking at me as much. Those are telltale signs that would make one suspect infantile spasms.
So if I'm hearing you correctly, there's really two signs. One is that regression in development, and then the second is that cluster of abnormal activity, right? So those are two things that both parents and emergency room physicians and or pediatric primary care physicians can be in dialogue about, right? That's something that they can ask, oh, have you seen any regression in neurodevelopment? I mean, typically a parent will offer that, but if a parent doesn't offer that, certainly that question can be asked.
Exactly.
And secondly, it can be something like, have you noticed a pattern of abnormal activity upon waking, or, you know, prior to go to sleep, or at different parts of the day, but they happen more kind of upon waking up and going to sleep. Is that right, Dr. Tran?
Yeah, typically upon waking up.
Okay.
Yeah, I see key words that, you know, when you're taking the history, key things that make the red flags that go up in my, you know, my antennas are like clusters of repetitive movements associated with waking up from sleep. And then afterwards, the child will cry. Usually they're irritable and they're crying afterwards. And then if you hear those like kind of buzzwords, repetitive movements, clusters, sleep, waking up from sleep, and then they're crying afterwards. Those are the buzzwords to be like on the lookout for. And if they offer some developmental history, perfect. If not, then follow up with that. Have you noticed your child not smiling as much, or any changes in development in the last couple of weeks? And that's very helpful to recognize and to refer appropriately.
Thank you. So Dr. Z, so let's say a doctor recognizes that, or asks, a parent comes in and says, I'm noticing this with my child, and they're in the emergency room, or even the primary care setting for that matter, with their pediatrician. And they go through, you know, the buzzwords, so to speak. So what happens next? Because, you know, we've seen, I mean, Mickey's miracles exist because, like Dr. Tran said, unless you know someone who knows someone, you know, the path to a level 4 pediatric epilepsy center is a difficult path. And we've seen, you know, months and months of delays from a pediatrician, you know, referring to a neurologist, and then months and months and failed treatments and increased medications, and not getting to the underlying reason for these infantile spasms, like you addressed in your opening remarks, and just treating it, you know, without really understanding why it's happening. And then months and months later, you know, they might get a referral to level 4 pediatric epilepsy center. So if those things are present, if those kind of red flags are present, you know, what's the best course of action for a primary care pediatrician or an emergency pediatrician to take?
Well, I consider infantile spasms to be a medical emergency, and most pediatric neurologists do. It's not something that you schedule an appointment for a pediatric neurologist because there's a critical workforce shortage of pediatrics down the road. This is the type of epileptic encephalopathy where you need to, the ER doc, the primary care, the phone, and call a pediatric neurologist or epileptologist directly and say, this is what I'm observing. Parents are really good at taking videos these days, and most of them already have videos of this child emergency. If we get a call like that, we admit the child to the hospital because there are two things you want to confirm. Are these you want to see the movements, and then is it corresponding with the abnormal EEG that Dr. Tran already described, a hips arrhythmia pattern, which think of it as there are normal brain waves that we see on an EEG, but with a hips arrhythmia pattern is chaotic, it's high amplitude, multifocal electrical discharges, if you will, on the EEG. And that coupled with seeing the infantile spasms makes the diagnosis. Once we make the diagnosis, there are specific approved, FDA approved management strategies. And second of all, it takes us on a diagnostic workup to determine, is there an underlying malformation in the brain? Are there underlying genetic reasons for this, for causing the infantile spasms? So it's kind of a two-pronged attack, but it's not something that you can say, oh, just schedule an appointment with a pediatric neurologist. And in fact, if you're in a larger area, rural America, it's a little bit difficult to maybe get an epileptologist, but pediatric neurologists are well-trained in infantile spasms. And if you see a child with these kinds of very stereotyped, that's the other part to emphasize, cluster of movements. So these aren't normal baby startles, and parents know that. If you see it, you make the diagnosis, then you can embark on the management and diagnostic strategies. And it's important, there's a 6 to 8 window of opportunity for treatment where there's optimal effects. And oftentimes, both Dr. Tran and I have seen children who have had infantile spasms for months, years, unrecognized, untreated. Early and start the treatment, you can normalize the EEG as well as eliminate the infantile spasms.
Thank you, Dr. Z and Dr. Tran. I have we hear these terms and we hear these stats and we hear the delay. And to me, we know at Mickey's Miracles, it's a medical emergency. We deal with parents who many times have lost hope even, and are seeing their child continually fall behind and even their livelihood be threatened, let alone have a quality of life. So when we hear terms like a medical emergency, I think because we're so close to this, we get that, right? We understand that. For a parent at home or a primary care, pediatric physician who may not have the same kind of attachment or closeness, what does a medical emergency mean? Like what are some of what have you seen in your experience, in your practices, with families for, some of the results or consequences of undiagnosed or untreated IS for some of these children you've had the opportunity to care for? Like, what are some of the consequences?
Yeah, so for kiddos with infantile spasms, and if we're not able to stop them or not treat them appropriately and they go on and continue to have spasms, they actually evolve, their seizures evolve, and they go on to have other seizure types, alrighty? A lot of these children I've seen evolve and have tonic seizures, or they can have other seizure types like drop seizures. So the eye movements or something that the head drops and they can actually drop to the ground, called atonic seizures. And so these children with untreated infantile spasms or inadequately treated the treatment isn't all or nothing. We'll get to that later. But if we don't treat them adequately and aggressively, they evolve. These children evolve to have other seizure types, different seizure types. And most of them do evolve and have what's called Lennox-Gastaut syndrome. So it's a syndrome, like syndrome's a constellation of symptoms that are common in a syndrome, right? So Lennox-Gastaut syndrome is an epilepsy syndrome in children that have multiple seizure types, developmental delay, and abnormal EEG finding. Like I said, there's patterns of EEG findings that are associated with certain syndromes. So there is yet again another pattern that's associated with Lennox-Gastaut syndrome, or LGS. And a lot of children that we meet later on in life as a second or third opinion, and they have a diagnosis of LGS, they often have a history of infantile spasms or spasms. And oftentimes the spasms are not completely treated, or we have difficulty controlling, and these children over time evolve to have different types of seizures, and essentially refractory epilepsy, meaning epilepsy that's difficult to control on 2 or more medications. And so that's the downstream downside to untreated or undertreated infantile spasms. It's just children, like I said, we want them to live life to its fullest, but unfortunately they are not able to. Most of them go on to have neurodevelopmental disabilities, and they go on to have different refractory epilepsy, and oftentimes have LGS. And these have significant impact on their quality of life. Their developmental disabilities and intractable epilepsy, and having to be on several different medications altogether have a negative impact on their quality of life. And as physicians, our goal is to maximize a child's quality of life. And if there's anything we can do to minimize bad things, so to speak, and maximize things that they maximize their quality of life, that's really our goal here, is to provide the children the best chance at a good quality of life here. So if an emergency room doctor or a pediatrician, you hear like, okay, I have concerns that this child I'm seeing in my office or in the emergency room right now has infantile spasms, I would call a neuroconsult. Okay, a general neurologist does not necessarily have to be an epileptologist. Child neurology, as part of their training, are trained to recognize this. Alrighty, so just get on the phone and get a neuroconsult with a child neurologist. And if you're in a part of the country where you don't have a child neurologist, because there is a shortage of child neurologists, adult neurology oftentimes are also trained, because as they're part of their training, they do have some child neurology training. But get on the phone, preferably a child neurologist, but if not, at least a neurologist, and say, I have a child that have concerns for infantile spasms. And the next step that they should do is make appropriate recommendations, which include most of the time hospital admissions for an EEG study to confirm the diagnosis and make the appropriate medical management recommendations.
And as both Dr. Tran and I have said, it's really important. When I say medical emergency, that doesn't mean the child's going to die in the next day or so. So we should define that.
Yes.
But that time is of the essence. So this is an urgent problem that requires management within the next couple of days. Because the earlier you diagnose infantile spasms and begin treatment, the better the outcome and quality of life for that child, irrespective of the underlying cause. So that's what we're trying to emphasize here.
Yeah, and you said there's a 6 to 8 week window that's ideal, that's optimal for from the beginning of that cluster activity and the abnormal brain activity. That window is 6 to 8 weeks. So if you start to get outside of that window, the potential for impact on quality of life and neurological developmental issues start to present more. Is that accurate?
Yeah, I think what is important, and Dr. Tran heard me say this before, but brain cells that seize together network together, and a baby's brain is very vulnerable. It's still in the process of being formed. And so if you have these abnormal electrical discharges that are ongoing, the brain, instead of being hardwired for normal development, gets hardwired for continued excitability and continued seizures. and also produces an underlying abnormality in how the brain processes information. And
Right.
so it sets you up to have a brain that's hardwired for continued seizures and developmental delay. So that's why we say, you know, the 6 to 8 week window is ideal. That doesn't mean if we get a child where they've had infantile spasms for 6 months, we just say, oh, all bets are off, we're not going to treat.
Right.
Yes, we're still very aggressive about treatment, but the ideal window of opportunity is 6 to 8 weeks.
And let me ask you guys a question, because we've heard, you know, multiple references to this neurological regression, if you will. You know, how does that show up in a child? I mean, we've seen it obviously because we're around it, but for a primary care physician at home or a parent at home that maybe doesn't have the same kind of experience or exposure that we collectively have. You know, how do those neurological developmental issues present themselves or show up in a child's you know, daily life?
So it's things, just to really say, it's like things that child's able to do, they no longer do already. For example, they were starting to coo or babble or start to make some vocalizations or some speech development, they start regressing. So often, in my personal experience, oftentimes I hear these parents say, yeah, they stopped babbling, they didn't talk as much, they're not talking, it's not as interactive.
Mm-hmm.
They lose their eye contact, they're not as interactive, they're not doing what they used to be able to do. And over time, so development, which is a range, it can vary too, but they're always behind their peers. I think the best way to really describe it is compared to other kids their age, they're behind. And the degree of how far behind they are vary from child to child. So I can't really put a number or say all of them will do this. But in the patients I've treated with infantile spasms and or were not adequately treated, compared to their peers of the same age, they're behind. And we try to close, our goal is try to close that gap and prevent that as much as possible. Again, it depends on the underlying etiology. I definitely have children where we successfully treated their spasms, but because of the underlying etiology, they write their own course. So they are also behind. And I think my argument to still treat aggressively is to prevent that gap. So if there's children, their peers, and here's my patient, and this is what the gap is, I want to do what I can to close that gap as much as possible. And so I think our goal in terms of development is to prevent that gap to be as big as possible and try to close it as small as possible so they are not too far behind. And so that's as much as I think in trying to be broad and encompass the spectrum of what I've seen. I think that's what I'd like to just leave it as. It's like I'm trying to, these children do fall behind compared to their peers, and we want to do as much as we can to have them not fall as far behind as they would have. Yeah,
that I've heard Christy describe when she first started noticing Mickie start to fall behind in development, and some of those signs that you've talked about were present, and that's what caused harm, and that's what kicked in the mama bear instinct that she had, and you know, she was tenacious and finally getting a referral to Dr. Z and CHOC, and obviously, you know, having Mickie have surgery, you know, a day before she turned 1, and she's been seizure free now, I think going on 8 years. But that's from our experience, that seizure freedom, 8 years in particular, seems to be rare, you know, from the families that we encounter. And a lot of the times is because of that delay in the diagnosis and, you know, correct treatment following the diagnosis, and even dealing with the underlying cause, right? I think with Mickie, there was a malformation of, I forget exactly the terminology. It's, you know, it's such a complicated thing for a layperson, but you guys found the underlying issue and were able to deal with the underlying issue through the brain surgery. Anything to add to that, Dr. Z? Or?
Well, no, I think in Mickie's case, when we did the MRI scan, In fact, I think we knew about the malformation when Christy brought the actual copy of the MRI. It was obvious there was a malformation in how the brain formed in a particular area of the brain that we were able to resect successfully.
Yeah.
And that eliminated the infantile spasms and eliminate the seizures. So that was very gratifying for all of us. I mean, that's what we as pediatric epilepsy specialists, when something like this happens, you go, wow, we made a difference, which is what we can all rejoice in. Sometimes it's much more complicated than that, depending on the underlying cause. If, for example, the entire brain is malformed, like with lissencephaly, which is smooth brain, we may be able to eliminate the infantile spasms, but the child will never be developmentally normal. But that being said, Dr. Tran is exactly right. You eliminate the spasms and you at least eliminate one factor that keeps their development from improving. And so you normalize as much as possible what you can treat. And so, but finding the underlying cause is really important, not just for management strategy, but also parents want to know what happened. Is this going to happen again? What can I anticipate in the future? And being able to give a diagnosis, even if it's not a good one that you can cure, is still helpful to parents. So that's what I would emphasize is it's not just enough to treat and manage the infantile spasms, but really be relentless in shortening what I call the diagnostic odyssey and being very precise with doing your diagnostic tests. So there's so many stories, so many children that we've been able to help over the years, children and their families. Sometimes we aren't as successful as we'd like to be, but it doesn't mean we don't stop trying.
Yeah. Well, Dr. Tran and Dr. Z, we're so grateful for the work that you guys do. We have seen firsthand the impact you've had on families and on children in particular. Mickie's very close to us, so we talk about her often, but thousands and thousands of families have benefited from your care and your expertise. And thank you so much for making this your life's work. You're making a massive difference. We're grateful to have such talented people and such caring people taking care of our babies, and really helping us to educate the world. And in this case, primary care physicians and emergency physicians in pediatric care to understand, what to look for, what to listen for, and what to do next. And that's an important gap because as we've heard today, every day does really matter. It matters between, a quality of life and potentially non-quality of life or even something more catastrophic. So on behalf of Christy and Mickie and our board of directors and our entire staff at Mickie's Miracles and the families we're honored to serve, because it's an honor to serve these warrior families. We thank you for your service and for helping us spread this awareness about the dangers of infantile spasms and helping educate primary care physicians and emergency physicians on what to look for, what to listen for, and what to do. Thank you.